But with no further ado, Dr. McAchran is here today to give us a talk, and the residents wished it was a little bit earlier prior to in-service, but this is all very testable information. A brief on Dr. McAchran. So she did her MD at Vanderbilt, residency at Case Medical Center in Cleveland, and then her FPMRS, I guess the fellowship formerly known as FPMRS, now ERPS, at Cleveland Clinic. She then joined us here at UW in 2008. Has really built a very impressive integrated specialty care clinic for women. She's an associate professor in our department now. Also is vice chair for faculty development and wellness, the dyad lead for outpatient urology, really a leader in our department without doubt. Recently was selected to participate in the AUA executive leadership program coming up in February, and is here today to give us this wonderful talk on a neurogenic lower urinary tract dysfunction. Thanks, Sarah.
Thank you very much, Dr. Richards. I was elected to participate in the course that Dr. Richards is teaching. So sorry this is a day late and $1 short for the in-service. Hopefully still helpful. On several of the slides, you'll see a little test icon in the corner because that's extremely testable material. This is all, if you guys remember or don't know, all of our grand rounds are in the UW box file under the core curriculum by year, so always reviewable in the future if you would like to. Dr. Santiago, our newest neurogenic bladder specialist, will be giving a secondary kind of follow-up lecture to this, talking more about the surgical treatment of neurogenic bladder. So we're going to focus today really on the 2021 guidelines, and I want to hopefully by the end of this have you all have a framework and approach for thinking about this population of patients, how you'll approach them if you see them in your office, particularly when you head out and hang your own shingle. Oh, let's see if I can get that to work. Okay, I have to click that. Okay, so we're going to talk about the guidelines. We're going to talk a little bit about what's normal function, what's dysfunction, how do urodynamics fit into the evaluation of this patient population, the current updated recommendations for surveillance, mostly non-surgical management today, and then some specific conditions. So the AUA SUFU guidelines on adult neurogenic lower urinary tract dysfunction, or NLUTD, came out in 2021. There's 60 guideline statements. It's fairly dense. This is what it goes through. If you're going to know anything from those guidelines, it really is this figure, or figure 2. Figure 2 wants you to start thinking about this really disparate patient population as either low, moderate, or high risk. And that risk is the risk of complications. That's what we're talking about here. So that risk is multifactorial. It's going to include the lesion location, the etiology of the dysfunction, clinical findings from urodynamics, from your post-void residual, from imaging. And then once you risk stratify these patients, it gives you ideas about how you should follow them going forward. So when I'm talking to my patients about the urinary tract, I try to make it as simple as possible. I'm not always great at that. But I talk about the kidneys are a faucet that's always turned on, and the bladder is a reservoir or a pitcher. As you guys know, bladder is basically a big giant muscle that stores urine and then empties on command, ideally after you're potty trained when you want it to, and empties out through a urethra. That urethra runs through a sphincter. So normal urination, right, doesn't require much thought if everything's working the way it's supposed to. Combination of both voluntary or conscious and involuntary or automatic muscular actions that allow you to store urine when you want to and release it when you want to. But behind all of that is a really, really complicated neurologic process that involves the entire neurologic system, from the white matter in the front all the way down out to the end organ, which is the bladder and the sphincter. And so if there is an infarct, impact, or injury to any part of that system, these patients can have some neurologic effects from that. So breaking it down into a very simple cartoon, at the top there is a flow curve, and then in the middle, a pictograph of what's actually happening as you fill and empty, and then words. So as you are storing, bladder pressure should be low. When you go to empty, bladder pressure should rise to squeeze and push urine out, and then be low again. This is what the picture should look like. And then what's actually happening? Well, the bladder muscle or detrusor is staying relaxed during the filling phase, with the urethra staying contracted. Somewhere around here, you decide to go to the bathroom, you're in a socially acceptable place, and your brain sends information downstream that says, please go into emptying phase, which leads the detrusor muscle to contract and the urethra to relax in a very coordinated, timed fashion for things to work perfectly. And then you go back into storage phase. So the lower urinary tract innervation can be divided into 3 areas. The pelvic nerve, which carries parasympathetic input via cholinergic receptors, primarily M3, is involved in voiding. The hypogastric nerve carries sympathetic input for bladder contraction via norepinephrine receptors, and then the pudendal nerve is involved in somatic control or bladder contraction. The sympathetic nervous system via the hypogastric nerves is involved in storage. So the neurotransmitter norepinephrine stimulates beta fibers, which have a negative effect on contractility of the bladder. Norepinephrine also stimulates alpha fibers in the urethra and the bladder neck, which have an effect on closure of the urethra. And the somatic nervous system comes via the pudendal nerve. The central nervous system can be thought of as having a switch, an on-off switch for storage and voiding. So that's what's happening up here in the white matter, deciding, okay, I want to go to emptying phase. Sends information to the pontine micturition center. That's really the switch. So that's the substation that sends a bunch of information downstream that says, I want to be in storage phase or I want to be in emptying phase. So during filling and storage, these are dense, I'm going to read them. Filling and storage is a passive phenomenon that's dependent on the ability of the bladder to stretch and accommodate different volumes of fluid. And that's dependent on the lack or no parasympathetic excitatory input. There's an increase in outlet resistance by means of the somatic striated sphincter or the guarding reflex. And then the sympathetic reflex also contributes to storage by increasing outlet resistance via the smooth sphincter, by inhibiting parasympathetic input, and by causing a decrease of bladder and smooth muscle tension. So continence is maintained during increases in intra-abdominal pressure by the intrinsic competence of the bladder neck, or the intrinsic sphincter, and the proximal and mid-urethral competence, external sphincter. Storage is further activated by the A delta fibers, which stimulate sympathetic efferents via the hypogastric nerve, which causes relaxation of the detrusor and contraction of the bladder base and proximal urethra. Somatic efferents via the pudendal nerve, causing increased striated external sphincter tone, and then the inactivation of the parasympathetic nervous system because of that sympathetic inhibition. Voiding, initiated by the cerebral cortex, like we talked about. The first thing that happens is the sphincter relaxes by inhibition of those somatic efferents, and then inhibition of the somatic efferents and activation of those parasympathetic efferents cause the bladder muscle to contract and further urethral smooth muscle relaxation. So the folks at the highest risk for the most devastating effects of neurogenic bladder occurs when flow from the pontine micturition center to the sacral micturition center is interrupted. And that normal opposing relationship between the detrusor and the sphincter is lost. And the degree of that interruption correlates with the risk for storage and emptying dysfunction, so the symptoms that the patient has, as well as the risk for upper urinary tract deterioration. And we'll get into more of that later. Some of the common causes of neurogenic bladder are classified here. I'm not going to read the whole list, but suprapontine causes like a stroke or traumatic brain injury. Infrapontine, that can be spinal cord injury, spina bifida, transverse myelitis, and then infrasacral, which is a lot of the pelvic surgery that we see here. What are the long-term complications of neurogenic bladder? The big scary one that we are all worrying about and trying to prevent, and the reason we do surveillance for these patients, is upper urinary tract deterioration, which is caused by vesicoureteral reflux, which leads to hydronephrosis and renal dysfunction. Lots of problems with continence or incontinence or trying to get the urine out. So urinary incontinence is an issue. Urinary tract infection, patients who don't empty their bladders effectively or who don't move as much are more prone to stones, and then malignancy. So what can go wrong with the reservoir? Well, it can be underactive, so not squeeze appropriately, or non-contractile. It can be overactive or squeeze when you don't want it to. It can be overactive all the time, which can lead to a small capacity bladder with decreased compliance. What can go wrong with the outlet? Well, there's some non-neurogenic things like stricture, or BPH. There can be functional obstruction, so there's no actual blockage, but the ability to squeeze and relax the sphincter at the same time are uncoordinated. And that's what detrusor sphincter dysynergia is. Or it can be hypotonic, and that's mostly what I see, right? Patients who have stress urinary incontinence. When the flow from the pontine micturition center to the sacral micturition center is interrupted, again, that normal opposing relationship between the detrusor and the internal external sphincter is lost. And that's what leads to that most devastating problem of problems with compliance. So I want to shout out to Dr. Ed McGuire and his fellow, Dr. Ann Gormley. Dr. Gormley is currently the chair at Dartmouth and has been on all the boards, right? A former trustee of the American Board of Urology, a member of the, certainly of the AUA University, and former president of SUFU. While she was his fellow, they did lots of the groundbreaking research on bladder compliance, which culminated in this editorial that was published in 1994, which really has allowed us to, which really revolutionized the care of patients with neurogenic bladder. So studies by Dr. McGuire and Dr. Gormley in the 80s and 90s identified altered bladder compliance, or that loss of the ability of the bladder to store under low pressure, as the main determinant of upper tract deterioration, and thus the urologic morbidity that was associated with that. It's worth a read. So how does poor compliance lead to renal failure? Well, so someone suffers a spinal cord injury. They then have unopposed parasympathetic output to the bladder, which leads to urine being stored at high pressure. That urine being stored at high pressure overcomes the normal valve mechanism of the ureters, which causes vesicoureteral reflux, and the ureter can't deliver urine downstream into the bladder. That means the kidney can't drain. Over time, the architectural change is hydronephrosis. The mechanical or the functional change is post-renal obstruction and ultimately renal failure. There are a lot of different ways to classify lower urinary tract dysfunction, and you'll read about different ones if you're reading about this population. There's neuroanatomical, the LUTD classification, which I feel like is largely of historical interest. Functional, which is primarily what the AUA core curriculum has people think about, failure to store, failure to empty, and then there's urodynamic classifications. They're all just a little bit different. Neuroanatomical is a good one to at least have a working knowledge of. So it's based on the portion and the severity of the nervous system that's affected. So it's classified into suprapontine lesions, suprasacral spinal cord lesions, sacral spinal cord lesions, and then cauda equina or pelvic plexus lesions. And the location of injury can predict urologic function over time. So a suprapontine lesion like a stroke or Parkinson's disease or dementia is a lesion between the cortex and the pontine micturition center. Most of these patients will present with detrusor overactivity or urge type incontinence, but have coordinated sphincter function. Suprasacral lesions like multiple sclerosis, a spinal cord injury, transverse myelitis, if it's between the pontine micturition center and S2, but above T6, will have detrusor overactivity, smooth and striated sphincter dysynergia, and autonomic dysreflexia. Below T6, less likely to have autonomic dysreflexia. Below S2 and peripheral lesions like diabetes or pelvic surgery like an APR or a low anterior resection can lead to detrusor areflexia, open smooth muscle sphincter, and a fixed striated sphincter. So this is a sneaky question that sometimes comes up. 1 month after an L5 laminectomy, a 30-year-old woman develops lower extremity weakness. She has a post-void residual of 300, an intermittent urinary stream. Urodynamics demonstrate DSD. So the most likely explanation is pseudodysnergia, recurrent lumbar disc herniation, cauda equina, undiagnosed MS, or a permanent nerve injury from the laminectomy. Dr. Sorrell is raising her hand. Undiagnosed MS. Why? So, yep, so she is, of course, completely right. Undiagnosed MS. So the patient has detrusor sphincter dysynergia. DSD occurs when lesions below the pontine, with lesions below the pontine micturition center, but above S2. But remember that the cord level, doesn't coordinate with the vertebral level, right, in the distal cord. So for DSD, the injury or insult should be above L2, actually, bony level, where the cauda equina starts. So that rules out everything other than undiagnosed MS in that question. The Lapides classification, as I said, I think is confusing, and we're not going to really talk about it. Functional, failure to store, failure to empty. So a failure to store can be because of the bladder or be because of the outlet. Failure to empty can be because of the bladder or the outlet. Because of the bladder, failure to store is going to be detrusor hyperreflexia or detrusor overactivity or impaired contractility. Because of the outlet, neurogenic intrinsic sphincter deficiency. Failure to empty can be due to detrusor areflexia or impaired contractility. Because of the outlet, it could be to DSD or bladder neck dyssynergia. So getting back to assessment and risk stratification. First, what are we trying to do? What are our goals of urologic care for this population? Well, one, of course, make sure our goals are in line with what the patient's goals are. We are the protectors of upper urinary tract integrity. As much as we can, we want to try to maintain continence. We want to try to minimize the potential complications that can occur, such as stone formation and urinary tract infection. And by doing all of this, hopefully improve quality of life and prolong life expectancy. So getting back to figure 2, our testable figure 2, everything starts with here, initial evaluation of the patient, right? And that should include, first, what's the neurologic diagnosis? Because we know that that gives us some idea of what we can expect and how we can start classifying these patients. When you do your first visit, we want to know, when did it start? Are you seeing someone 20 years into their diagnosis? Were they just diagnosed yesterday? What's the severity? What's the prognosis of this particular diagnosis? What's the potential for recovery, if any? How much functional limitation is there because of this? And then certainly it's important to know if a patient has a VP shunt. We want to know how they've managed their lower urinary tract from the diagnosis to now. And for some patients even, how did things work before you were diagnosed with this problem? We want to know what their lower urinary tract symptoms are, their sexual and fertility functioning goals, bowel function and regimen. We want to get some assessment of skin integrity. Do they have autonomic dysreflexia? And if so, what are their main triggers? What is their renal function? Do they have prior imaging? What complications have they suffered so far before getting to your office? What functional limitations do they have? What kind of support mechanism do they have at home? How much help? What are their goals? And then certainly there are other urologic issues not related to this. The physical exam should include some mental status and cognition assessment. Should certainly include a urinalysis and pretty much a PVR for anybody who voids spontaneously, because that's a main determining factor in terms of risk stratification. Might include avoiding diary, might include pad tests, might include non-invasive uroflows. So the tools that we have for assessment, urinalysis and culture, we talked about that. A PVR, very important. Possibly ultrasounds, we've got blood work, we have just an office uroflow, and then more complex urodynamics. And that information initially is going to help us separate people either into low risk or we don't know quite yet and we need to do some more testing. So low risk folks tend to be patients who have suprapontine lesions, stroke, Parkinson's, traumatic brain injury, or a lesion very distal to the spinal cord, so pelvic surgery, diabetes. These are folks who void spontaneously with lower residuals, no other complications. Their renal function is normal, or if abnormal, stably abnormal. They have synergistic voiding on urodynamics if you've gotten those. Their upper tract imaging has normal renal architecture, and they have stable symptoms. Unknown risk at this point is everybody else. So how do we figure out unknown risk into moderate or high? Well, we have some tools for that: imaging, urodynamic testing, and renal functional testing. That's what's going to allow us to stratify a little bit further. We're going to talk just a quick bit about urodynamics. Why do we do urodynamics in this population or in any population? Well, to answer a specific question. So urodynamics really should, when you order them, you should have an idea of what you're trying to figure out from them and how that will change your management. So in this population, we want to provide documentation of the effect of the neurologic disease on the lower urinary tract. Try to correlate whatever we see with the patient's symptoms. Why are they leaking? Why is their PVR 500? okay? And then assess for the presence of urologic risk factors that could be associated with bigger problems and put them in that high-risk category. So detrusor sphincter dyssynergia would be one of those. Poor compliance is one of those. Sustained high-pressure detrusor contractions can be that, and then certainly folks who have reflux. Why do we need to do urodynamics? Because bladder behavior cannot accurately be predicted by the level of injury. So if we go by neuroanatomical classification, that's a good guideline, but it's not always predictive in every patient. And as they say, the bladder is an unreliable witness. So a person with diminished compliance can have zero symptoms from that until it's evidenced, until you find out later that they have massive hydronephrosis bilaterally. So urodynamics can identify patients with increased storage pressures or increased outlet resistance for whom early intervention is going to make a big difference in their life expectancy. Complex systometrics. So this is the cartoon from Netter, which is old, but I still like it, showing what we're actually doing with urodynamics. It's sometimes a good idea to try to remember this. In this cartoon, they're showing a filling catheter going into the bladder, and they're showing a pressure sensor in the bladder. And that's going back to our P vesicle pressure. There's a catheter in the vagina here, but often we usually, here we typically put it in the rectum. That's giving us an estimation of the intra-abdominal pressure. From the measurements of the intra-abdominal pressure and the vesicle pressure, we can calculate the detrusor pressure, which is the thing we're most interested in, right? We've got some patch electrodes on the perineum, which give us some idea of what the sphincter is doing. So that's our sphincter EMG. And as we fill and empty, that gives us our systometrics. A filling systometrogram, that's what we're seeing over here, should mimic filling and storage. And it measures compliance, right? The change of volume over changes in pressure. And it evaluates for involuntary detrusor contractions, which is what we are seeing here and here, if it's happening during the filling phase. Someone shouted out, what's the number above which we worry about compliance? Can't be Dr. Sorrell. .40, exactly. I know you all know that. Storage pressure is greater than 40. Water results in upper urinary tract deterioration. So if you're going to remember any number, that's the number to remember. Over here, we're seeing a patient with poor compliance. As the volume changes, the pressure is changing significantly. Normal would be a nice flat line. The voiding phase or fluimetry assesses for detrusor function and primarily can try to assess for detrusor sphincter dyssynergia. So what we're seeing here is the patient's given permission to void, right around here. The detrusor is contracting with pressures up to about 100 centimeters of water, as you might see in someone with BPH, but let's assume that this person doesn't have BPH. So we're gonna go down and take a look at their sphincter activity, and it's off the charts there, right? So that would be a nice picture of detrusor sphincter dyssynergia. Fluoroscopy can add a fair bit of information to a video urodynamic studies, particularly for the neurogenic population. It can help us assess for reflux, right? We get a VCUG basically right there when we're doing this. It can assess for architectural changes to the bladder, like large diverticulum, multiple cellules, trabeculation, and it can help us assess for DSD by actually functionally watching what's happening as the patient's attempting to void. In terms of reflux, that's what we're seeing here, right? A markedly abnormal bladder with reflux up into the ureter on that side. And if we followed everything up, we would see massive hydro on that side as well. This is a high risk patient, right? So expected answers from a urodynamic study, we get answers about bladder behavior. Is it overactive? Is it underactive? What's the compliance? At what point do they sense that it's time to go, that they should go to the restroom? What's the systometric capacity? We can get information about post-void residuals. Is it a high pressure system? Is it a low pressure system? We can get some information about urethral behavior. Is it hypertonic, hypotonic? Is it unstable? And we can get some information about micturition as well. There are urodynamic classifications of neurogenic lower urinary tract dysfunction. Those are listed here. Brief foray into autonomic dysreflexia. Who gets this? Patients with spinal cord injury at or above T6, but you can certainly see it with a T7 or a T8 lesion as well. Why do they get it? Noxious stimuli, such as a distended bladder, for instance. Below the injury, which sends afferent stimulus, which generates massive sympathetic overactivity. And what are the clinical signs of that? hear people whispering. Someone shout. Megan. Hypertension, bradycardia. Hypertension and bradycardia. So they get pressures over 200, heart rates of like 30. It's remarkably terrifying when it happens in the clinic. Really terrible headache. They'll be flushed and sweating and have some nasal congestion as well. So what do we do about that? Well, these are any patient who is at risk should be monitored, and we do that in our clinic. Anytime someone has a symptom of this, the first thing you do is alleviate that noxious stimuli. For us, it's almost always drain the bladder. Anybody who's supine, place them upright. The orthostasis, just from going from supine to upright, can help decrease the systolic blood pressure. And then if no improvement with those interventions, Dr. Santiago is coming up with a protocol for this. I think we have nitrate in clinic now, nitro-paste in clinic. Nitro-paste applied above the level of the lesion. I have never given sublingual nifedipine in clinic. So getting back to risk stratification, we know who our low-risk people are, and now we've done some urodynamics, we've maybe done some imaging, and we can start figuring out who the moderate and the high-risk people are. So a low-risk person, normal, stable renal function, low PVR, normal imaging, urodynamics demonstrates normal voiding. Moderate risk, normal function, maybe a slightly elevated PVR, they're not emptying quite the way they should. Urinary tract, still normal findings. Urodynamics might have some retention, might have some DO. And then the high-risk patients, all of it's abnormal, right? Certainly anybody with reflux, poor compliance on urodynamics, high storage pressures, architectural changes on imaging. So those are the folks that we need to worry about. And that determines surveillance. So a low-risk patient, you don't necessarily need to see in clinic yearly. That's someone probably who could go back to their primary care physician with any changes in urinary function or symptoms to come back, but they don't need regular upper tract imaging or urodynamics. Moderate risk patients, they do need some surveillance, probably annual appointments in clinic, annual functional tests, upper tract imaging maybe every 1 to 2 years, and urodynamics if there's new symptoms, new complications, they weren't getting UTIs, now they're getting a bunch of them, any change in their imaging or changes in their renal function. And then high-risk patients, you need to watch even more closely than that, right? So surveillance, H&Ps yearly, renal function yearly, imaging yearly, urodynamics not necessarily yearly, still with a reason to do it, which is different than when I was training. So GU monitoring for the high-risk patient should include an initial BMP, baseline urodynamics, renal ultrasound, yearly BMP and ultrasound, urodynamics if there are symptom changes, if there's an increase in the number of UTIs, or if there are ultrasound changes, and then follow-up urodynamics ordered for cause rather than just for screening. So management, let's get back to what are our treatment goals? We want to keep upper tracts looking normal. So we want to keep that filling pressure less than 40, storage pressure less than 40. Prevent infection, allow patients to store at low pressure, allow patients to empty at low pressure, and try to be dry. For an underactive or non-contractile bladder, we can have them empty it, either with CIC or with a tube, sometimes with electrical stimulation. For an overactive bladder or reservoir, we can do a bunch of different medications. We can inject Botox, we can do some electrical stimulation, we can augment it. And for a small capacity bladder with decreased compliance, we're really looking at that is a bladder that's not serving its purpose anymore. And we need to figure out a different mechanism for patients to get urine out of their body. So managing altered outlet function, if there's anatomic obstruction, like a stricture or BPH, you treat it. If it's a functional obstruction, we can try alpha blockers, sometimes beta-3 agonists, Botox into the sphincter itself. Actually having women just push or crede, a little more effective for women than men. Transurethral incision of the bladder neck or a sphincterotomy. And for a hypotonic bladder or stress urinary incontinence, all of the things that we do for stress incontinence. Just a brief review of these medications, because this also comes up. These are all of the anticholinergics that are available on the market. On the left is the generic name, on the right is the brand name. How do they work? Detrusor muscle is really rich in cholinergic receptors. These medications block the cholinergic or muscarinic receptors in the detrusor, which theoretically stabilize bladder muscle. There's also some influence on suburothelial receptors as well to mediate urgency. There's multiple muscarinic subtypes, but the main ones in the bladder are M2 and M3. The storage phase effects of antimuscarinic agents, they can reduce bladder tone during storage and increase filling capacity on a CMG. And again, M2 and M3 are the main receptors that we care about. M2 receptors take up 2/3 of the muscarinic receptors in the bladder, and M3 receptors appear to facilitate the contractile response in normal bladders. Remember our cartoon from before about beta-3 agonists. So antimuscarinics versus beta-3 agonists, they work differently, potentially complementarily. The anticholinergics keep the bladder from squeezing when it's not supposed to. Beta-3 agonists potentiate the bladder's ability to store. This is a nice picture for you guys to look at later. We can skip through that. This is actually, it should say Vibegron, not Virabegron. But Vibegron is the most recent medication introduced into this space. It was approved in 2020. It's still not widely covered by most insurance plans, but it is a single dose beta-3 agonist. Doesn't prolong the QT, and it has significantly less effect on blood pressure than Mirabegron, which just became a generic medication. So just an important thing I thought you guys should know about. A little bit of information about Botox. How does Botox work? Well, it decreases bladder muscles' ability to contract by inhibiting the acetylcholine release at the presynaptic anticholinergic junction. It's a really, really, really effective anticholinergic, right? That leads to regionally decreased muscle contractility and atrophy. Botox can be injected in the office or in the operating room. It wears off anywhere from 4 to 12 months, and has to be repeated. There's a cool cartoon about how it works. You guys should remember snare proteins. That's often the answer to that question. Botox was FDA approved in around 2010. It is approved at 100 units for idiopathic overactive bladder and 200 units for neurogenic bladder or NLUTD. We often go up to 300 units and more, but sometimes there has to be some fancy prior auth done to do that. Injecting anywhere from about 5 to 10 units per injection, though that is widely variable as well. Lots of studies showing that it works. In particular, the Dignity study was one of the first looking at it in neurogenic detrusor overactivity. We'll zoom through that. We can also use Botox for detrusor external sphincter dyssynergia or for DSD. In that case, we're injecting it 100 units. The way I do it is 100 units in 4 separate places and 25-unit aliquots at the external sphincter. Botox doesn't last as long in striated muscle as it does in smooth muscle, so it often has to be repeated a little bit more often for this indication, but it can be quite effective. And then I am skipping over surgical management in deference to time, and because Dr. Santiago is going to talk about it next week, 2 weeks, soon, and just go over some specific conditions. Spinal shock, right? This is often when we are going to be called or when we might start to get involved in a patient. So spinal shock lasts anywhere from days to months. It's a period of decreased excitability of the spinal cord segments at or below the level of the lesion, which results in an absence of somatic reflex activity and flaccid muscle paralysis below the level of injury. During this time, the bladder is acontractile. Bladder neck is generally closed. So these people are going to be in retention. And then the smooth sphincter mechanism is functional. And the normal guarding reflex is absent. There's no voluntary control. I think we're still going to stick to this, but generally we wouldn't do our first urodynamics until after the spinal shock phase is over, which is usually about 6 months. So about 6 months after an injury. Parkinson's disease. Parkinson's disease, remember, mostly is a suprapontine issue caused by the degeneration of dopaminergic neurons in the substantia nigra. The non-motor symptoms can be neuropsychiatric. They can have sleep disorders, sensory symptoms, but then also autonomic disorders. Most of these patients are going to have some bladder dysfunction. Usually, it's urinary urgency, frequency, and urge urinary incontinence. And our prime options for treatment are either anticholinergics or beta-3 agonists. Limited data on posterior tibial nerve stimulation in this group. Limited data on sacral neuromodulation. In my own personal experience, sacral neuromodulation can be helpful early on in the disease process. As the disease process progresses, it's less and less effective. If there's concomitant BPH, there was an old adage that you shouldn't do a TURP, that this was related more to discoordination between the sphincter relaxing the way it was supposed to due to the slow relaxation of the sphincter, but that has been completely disproven. So a TERP or a HOLEP may, I shouldn't even say TERP, a HOLEP may improve continence in patients with Parkinson's disease. So that's we can offer outlet obstruction procedures for BPH to this population. One of the variants of Parkinson's disease is multisystem atrophy. These folks tend to have early onset bladder symptoms and much more severe bladder symptoms. And often they have a much higher or more elevated PVR than folks who have just general Parkinson's disease. So if you are seeing someone with Parkinson's and you note this, it's an important thing to alert their neurologist to, because that's a much different disease pathway than just general Parkinson's. And in these folks, a HOLEP is unlikely to improve their symptoms. Nice article looking at how the urinary function can predict prognosis in patients with MSA. Multiple sclerosis. So risk stratification is difficult in patients with multiple sclerosis because their disease changes over time, right? They have plaques in different locations. It's not a stable problem. So risk stratification is dependent on the plaque location. So it's important for you to know what their MRIs look like. It's going to change over time. And generally, these patients are at least moderate risk. So they need surveillance. Yes. They probably need to come and see you at least once a week, or your APP. They need renal function testing annually. Upper urinary tract imaging, probably every 1 to 2 years. It's much more likely that a patient's going to have some upper urinary tract dysfunction if they have, if their legs are more affected by the multiple sclerosis. So the more disabled they are in terms of ability to walk, the more likely they are to have some more bladder problems and upper tract imaging changes. So I would follow those patients more closely. And then urodynamics, again, for cause, not necessarily yearly. Dr. Fowler from the UK is a name you should know in neurogenic bladder, and came up with this very lovely pictogram. This was published a long time ago in 2009, but it's a nice thing to keep in mind when you're thinking about different degrees of multiple sclerosis, what you can do for them from a bladder perspective, and how worried you need to be. Finally, take-home messages. Remember, as you're thinking about this, what are we trying to do? Right? We're trying to preserve upper tracts. We're trying to create as good a quality of life as possible. As good a quality of life as possible generally means continence and fewer complications, not coming in for UTIs, not having stones. Those at the highest risk for the most devastating effects are when that flow is when parasympathetic, when there's interruption between the pontine micturition center and the sacral micturition center, right? So that parasympathetic flow is unopposed, the bladder's in a constant contracted state, it becomes poorly compliant, doesn't store well over time. These are those folks. How does that work? We've been over it before, I won't do it again, but poor compliance leads to renal failure. This is how you should monitor those high-risk patients. Again, these are the people you need to be the most worried about. And because in 2 weeks, it's the Michigan-Ohio State game, go blue. Thanks. This is also Notre Dame Stadium in the background. That's for Dr. Knabler.
Questions for Dr. McAchran? I'll start with one.
You have to have a question.
No, I do. So with upper tract deterioration being the most, probably one of the most devastating complications in these folks, what percentage of patients will progress to that and lose renal function? Do you have a sense for that?
I mean, in this state, right, so I am not going to remember the exact data or age on, it used to be everybody with spina bifida, you didn't live past the age of whatever, 20s, 30s, due to renal failure, right? Before we understood that the problem was decreased compliance and we needed to manage that. Now we take care of spina bifida patients into their 70s and 80s. So, hopefully, if they have all of the good care that they need, we prevent renal failure from being the reason for death, the reason for lower life expectancy. But percentage at this day and age, I don't know the answer to that. Avi?
If you don't. had a couple questions. Very good talk. Thank you. So, are you answering a question right
Yeah,
now?
no, go
I
ahead.
see. So it's a little less related. So I would ask you, how recent are the current guidelines?
2021.
2021. So that's a little bit dated. What would you guess if you took 100 patients seen in a general practice, what percentage of those patients would be within the guidelines? What would you guess?
There's fairly recent. We know from a project that I did looking at the uptake of the microscopic hematuria guidelines that came out in 2020, that that uptake is not brisk of our urologic guidelines. We know that not everybody has read them, not everybody knows about them, not everybody knows that things have changed, despite lots of work on dissemination, right? So that's a long preamble to an answer which is probably not many, less than 50%.
Yeah, so my feeling on this is that in the United States, where the American Urologic invented guidelines, right? We invented it. Yet in the United States, we just don't update them enough. The NCCN guidelines, as the oncologists know, are updated annually. And, my feeling is, we have not done a good enough job identifying active, interested urologists to serve on guidelines panels. And what happens is everyone wants to be on a guidelines panel, but nobody wants to do the work. So we have all these experts that help with the data collection, and our repeated answers are there have been no changes. A good example is the Stone guidelines. A colleague of mine is in charge of them and basically says there are no significant updates for the last 4 years, which I completely disagree with. And the EAU guidelines are updated annually and published in the European Journal. So I think this is an area. We have an abstract this year submitted looking at sort of my uptake of the guidelines. And I think we all should consider that. There's a very good study on the bladder cancer guidelines, which I know had an uptick in utilization or follow-up of the guidelines because basically urologists were not, understanding the rate of cysto. But I think SUI in particular is an area where a lot of it leads to substantive procedures, both diagnostic and therapeutic. So I think it's an important question.
I might be wrong. I don't think I am. This 2021 this is the first iteration of that guideline ever. They were not written before. There are lots of different surveillance recommendations from multiple different, European urology, American spinal cord injury, different studies, and they didn't all align. So I think, what's kind of amazing about this is I think it really does, if you dig into it, give you a way of thinking about these people in your 15-minute office visit and taking care of them in, middle of Wisconsin, and figuring out who you can keep and help and who maybe needs to go and see somebody at a more specialized center.